Good afternoon, everybody. I am Dr. Nishith Chandra. I am Director Interventional Cardiology at Fortis Escorts Heart Institute, New Delhi. We are on the sidelines of India Live 2024 at New Delhi. And today I am privileged to have with me Dr. Alexandra Lansky, who is a professor of cardiology at Yale School of Medicine, Yale, and with an active interest in coronary imaging and research. Good afternoon, Dr.
Thank
Lansky.
you for having me.
So let's start. Is this your first time in India Live?
It's my first time in India Live. I have to say I'm very, very impressed by the whole meeting and the attendance and the organization and all the lectures that you have and the educational content. It's very impressive.
What was your topic here in India Live?
So I spoke about the use of invasive imaging to guide interventions and the role of imaging in improving outcomes.
So in your practice in Yale, what percentage of the patients you do coronary imaging, and how do you select the patients? Do you do in all the patients, or there are selective patients where you do it?
Well, ideally, we would all like to be able to do imaging, invasive imaging in everyone, but unfortunately, that's not the case. I would say overall, it's probably 20 to 30% of cases with invasive imaging, I would say at the institutional level. Some people do it more, some people do it far less than that. And I think it really has to do with the level of comfort. One of the things that we have put in place at Yale is that we're developing an imaging program where we have a dedicated faculty member with expertise in invasive imaging and physiology, who's come to essentially train all the interventional cardiologists and really help them to integrate it into their practice. And we're seeing actually change over time. It's actually increasing the number of cases where it's being used.
So 20 to 30% is a very impressive figure, because here in India we are struggling and the penetration of imaging is not more than 2 to 3%. So which type of the patients you would specifically look for that they should be included for imaging?
Well, I think when cost is an issue, and I assume that's the issue here
in India, because the patient pays from his own pocket,
right?
They are not reimbursed.
Exactly.
So that's why we have to select the patients very, very carefully.
So I think in those situations, you want to identify the highest risk patients, obviously left main interventions, in-stent restenosis or procedural failures, stent failures, I think very helpful to understand the mechanism of failure. And, as we're learning more about the treatment of calcified lesions and how best to modify the lesion and optimize the acute results, I think that's an area where invasive imaging is really needed. So
now, when it comes to invasive imaging, we have two modalities. One is a sound-based, which is intravascular ultrasound, and another is a light-based, which is optical coherence tomography. So how do you choose which modality in which patients, or do you interchange them? So how do you select your patients?
I think it really depends on what you're used to and what you have available to you. So some institutions have access to both. Some institutions have access to only one technology. And again, it also has to do with the comfort with the interpretation. So, OCT is more recent, and some people are less comfortable with OCT and the interpretation. I have to say that the more I see and learn about OCT, the more I think it's a valuable tool, because you're able to just define the plaque so much more, and you can learn so much more from the images.
Yeah, so what I have learned in my practice is that OCT has become a very invaluable tool, for, especially in acute coronary syndrome patients, like you have said it rightly, because it gives us a very good information about the plaque characterization, whether it was a plaque erosion, a plaque rupture, or a calcified nodule, because that information with an intravascular ultrasound is difficult to get. So
Exactly.
in my practice also, I prefer OCT in certain situations. But the drawback of OCT are because you have to give a dye. So if a patient's ejection fraction is low or he is a patient of compromised renal function, then their intravascular ultrasound is better.
Is
preferable.
preferred, right? Exactly.
Right. And also the left main lesions, on the ostial lesions, it's difficult to do OCT in them.
Mhm.
That's
Right.
where we do intravascular ultrasound. So now, what are the barriers of imaging penetration in your practice and in the developing world, according to you?
I think it's cost primarily. It's
Yeah.
cost, and I think it's a perceived time, additional time to the procedure, right? But ultimately, I think cost is really driving this. But having said that, I think that the results coming out from the trials and the evidence showing the benefit in the longer term in terms of reductions in revascularization, reductions in mortality. We were just speaking about the most recent meta-analysis that has come out, and we're seeing a 29% reduction in target lesion revascularization, or target lesion failure, I should say, at 26 months. That translates into a long-term cost benefit. And if you do the cost analysis, it really is cost effective. Having said that, obviously from an institutional perspective, the cost of the catheter and all the equipment is something that you have to pay up front. So I think that's the main barrier. I also think that it has to do with the comfort of the technology and being able to interpret it. I have to say, from our experience at Yale, there are some interventional cardiologists who are just not comfortable with the interpretation. They can do the image, but if they don't know what the image means or how to act on that. So I think that's also
that's a very important point you have brought out, because people sometimes they just do imaging just for the sake of doing it, and they don't interpret it and they don't act on the results of the imaging. They just pass a catheter, come out and do the imaging. So that's a very important point you have made, that you have to act upon the results. You have to interpret it correctly. And now, talking about the evidence, one very hotly anticipated trial was ILUMIEN IV, where people were expecting a positive result. But when it was shown, it was the results were declared in ESC, the people were disappointed. So how would you interpret those results, and where would the imaging practice go from here?
Right. I agree with you. I think we were all anticipating very positive clinical outcomes. I think there's multiple points to be made with that study. First of all, it was one of the largest randomized clinical studies that
2,400
patients, right? So enormous study. I think it was 80 sites, international.
Yeah.
And I think whenever you're taking a study like this and evaluating a technique, it is so operator dependent. And I fear that there probably was, although I haven't seen this evidence, but I would assume that there was some variability from site to site. So I think that's number one. I think what it taught us is that if you use OCT, and it is a protocol-guided, measures to optimize outcomes, you're going to see optimized outcomes, and we saw that, right? The
MSAs
MSAs were
high.
Better and significantly better. It just did not translate into improvements in clinical outcomes. It was an all-comer study, so there's a huge mix of patients, and I think we're pushing sometimes when we do these trials, we do them too quickly. We assume that it's generalizable, and I think we want to be able to say that it's generalizable, but sometimes it's too fast, too soon, and maybe that was the issue here. So, I think it needs to be put in the context of all the evidence that we have. And again, coming back to this meta-analysis that was just published in The Lancet just a week ago by Greg Stone and Ziad Ali, it's undeniable when you take the totality of the evidence. We're seeing in that meta-analysis 55% reduction in, or 45% reduction in mortality, all-cause mortality, cardiac death, reduction in myocardial infarction, reduction in revascularization rates, and very impressive reductions in stent thrombosis. So, I think we need to interpret the results of individual trials in the context of bigger studies. The other thing I'll say is that, we want to see benefits in terms of the hard endpoints, the death and the MI rates. It takes large numbers of patients to do that. And yes, we can argue that 2,000 patients is a large study. But if you think about the pharmaceutical studies, the ticagrelors and the prasugrels, we had to study 18,000 patients to be able to see clinical benefits. And it's the same here. It's no different.
And when Greg Stone did his meta-analysis, then he proved that it reduced major hard endpoints like mortality, MACE, which you have already said. Now, when Dr. Gary Mintz, he shows the evidence, his whole slide is full with meta-analysis, registries, and now with this humongous data of imaging, the favorable results of imaging, why still imaging has not become the class 1 indication by the guideline writers? Because there's a clear data now, data after data, meta-analysis after meta-analysis are proving that imaging supported PCI results in better outcomes, lesser stent thrombosis, lesser mortality. So why still this is still a 2A indication?
Yeah, I think that's a big issue. I don't know whether after this most recent meta-analysis we're going to see any movement on the guidelines. The guidelines like randomized clinical studies and p-values that show clinical benefit. So I hope they'll move, because I think, again, the evidence is undeniable. And I think we have certainly reached the point where we can say that in a very convincing fashion.
If I'm right, the China Cardiovascular Society, they have made it a class 1 indication for left main, for bifurcation and calcified lesions. Yeah. And another subset where I find it very, very indispensable, especially the OCT, is in the ISR, because that gives us a tissue characterization and give us idea about the reason of stent failure, whether it is a new intimal hyperplasia or new atherosclerosis or an underexpanded stent.
And it completely changes the strategy.
Yes,
if you put a drug-eluting balloon in an underexpanded stent, it's not going to do anything. So it's really mandatory in that.
So another question which I wanted to ask is, based on your imaging results in an ISR patients, how do you choose between a drug-coated balloon versus a drug-eluting stent?
Well, sadly for us, this is changing in the United States. But as you may know, the drug-coated balloons
are not available.
Not available.
Recently, I think
there's one recently, so it's just we're not there yet. It's going to take time.
Because in Europe and in India, we have drug-coated balloon for a long, and that is a dilemma when a patient comes with 2 layers of a stent and we don't with an ISR. So should we put another 3rd layer, or should we do the?
I would say drug-coated balloons. I think that's the value, and in Europe we've seen movement to. Even a 2nd layer of stent is not ideal, right? If you failed the first time and it's really based on intimal hyperplasia, you're putting another layer of stent, you're just reducing that lumen, and the results are not going to be optimal. So your recurrence rate is going to be much higher. So I think that a strategy of your initial treatment after stent failure should be, if accessible to you, drug-coated balloon. And if you fail after that, then you have additional options. But the more layers of stent, I think the higher the failure rate.
So this is one subset of the patients where, to our viewers, I would like to mention that a patient who is coming with a stent failure, this is a patient where you have to do an imaging, because you have to identify the mechanism of his failure, and then you have to act accordingly. So it was a under-expanded stent, you just have to expand a 1:1 balloon. If it is a new internal hyperplasia, you can use a drug-coated balloon, or if it is a new atherosclerosis, then you can put a DES. So this is very indispensable tool for ISR imaging. So what should be your message to our younger fellows who are embarking their interventional journey regarding coronary imaging? How do they incorporate in their practice?
I think it has to do with the training. So it starts with training and having access and getting comfortable with the interpretation of the images. I think that's number one. And I think, you know, as you go along, if you haven't had that opportunity, it's really being able to team up with colleagues or mentors that have this, you know, coming to conferences like this and really learning from the experts as you've been able to bring here to Delhi. I mean, it's very impressive. We've had 2 days of the best, the top, you know, talking about this. And I think that's been very educational. But then it has to be ongoing. You can't have just a one-time exposure and then hope for, you know, to gain all the knowledge. You need to be able to, you know, build on that. And I think, as you showed me just now, your app, I think, is going to be very, very good at that. But there's webinars from the societies, whether it's the ESC or SCI or ACC. I mean, there's training webinars. So it's all about education. It's lifelong learning, right? In this field, it never ends. And I think that's, on the one hand, it's what's so exciting about our field. There's always new technologies, new imaging. You know, now we're looking at artificial intelligence and the incorporation of AI in our image, in the OCT imaging, which is incredible. I mean, talk about making it accessible and easy to interpret. I mean, that is one huge step forward in closing that gap and you know, overcoming that barrier. So I think it's, you know, stay engaged. I think that's the key message, is just to stay engaged and continue to learn as you go down your career path.
So stay engaged, continue to learn, and focused on your career. These are the words of Dr. Alexandra Lansky for our fellows. Thank you, Dr. Lansky, for giving us time and opportunity to have a word with you, and have a safe journey back home.
Thank you very much.
Thank you very much.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.